I was asked to talk about first-line treatment for patients with intermediate and poor risk kidney cancer in 2019. And at least in my view, that's a pretty straightforward answer. Everybody who should be able to receive immune therapy should get Ipi/Nivo in the frontline setting. But I've changed the topic a little bit because I don't believe that we should be spending all of this time and energy focusing on who's intermediate and poor risk and who's favorable risk, because I don't think that those are the categories that are going to matter in the future. And I don't think we should be restricting our thoughts to just the FDA-approved therapies. So I'll be talking about frontline therapy for patients with clear cell kidney cancer. And I think what I'm going to go over is the data from the CheckMate 214 trial of Ipi/Nivo versus Sunitinib, and show that for intermediate and poor risk patients that Ipi/Nivo is better than Sunitinib in terms of response rate, overall survival, and quality of life, and is really not that much different in terms of PFS. And in the good risk patients, the activity of Ipi/Nivo is the same as the activity of Ipi/Nivo in the intermediate and poor risk patients, and the quality of the response is just as good, and the toxicity or quality of life is improved, and there are more complete responses and more durable responses than Sunitinib. So even though the response rate is a little lower than Sunitinib in the favorable risk patients, and the PFS median is a little bit lower, I don't see any reason to justify not giving patients with favorable risk patients a chance at curative as opposed to palliative therapy before you go on to VEGF inhibitors. I also will talk about the role of PD-L1 in that treatment selection, where I think it's too fluid, and not being PD-L1 negative is not a reason to consider immune therapy as your initial treatment. So then I'll move on to talking about where things are going, which is single agent anti-PD-1 and the trial from the Pembrolizumab KEYNOTE-427 trial that was presented at ASCO last year, which showed that a large part of the activity of Ipi/Nivo is from Pembrolizumab, is from the anti-PD-1 component of the treatment, and that if you're worried about the toxicity of the anti-CTLA-4 component in a particular patient, then one could just give single agent anti-PD-1 and see potentially similar response rate and maybe close to the same amount of complete response, and you could potentially salvage patients by giving Ipi to those patients who don't respond to frontline Nivo.